Welcome to the episode of Persivia Perspective. And today we have Sharon McGinnis with us, who is the Vice President of our client servicing team. So, our topic for today's podcast is hospital reporting. And in today's evolving healthcare landscape, hospitals are under increasing pressure to improve their quality measures and reporting. With new advancements like hybrid measure submissions and eCQM measures, it's becoming essential for hospitals to keep up with the changes. So, Sharon, my first question to you is this hospital reporting, like I said, has seen many changes over the years. But from your perspective, what are some of the significant changes or trends that you have that are hospitals are experiencing in terms of quality reporting today?
Thank you for having me this morning, Nita. So in recent years, the complexities of delivering quality healthcare has been increasingly more challenging. It's already difficult under the best of circumstances. Historically, hospital revenue, staffing, turnover have been of critical importance. Additionally, hospital mergers and acquisitions of standalone hospitals merging with larger health systems are also challenging in that they have to migrate into other organizations, and that takes some time to adjust. We also see a growing aging population. These are patients that have chronic comorbidities and chronic disease that are costly to care for and manage. Then they have a requirement to regularly update and maintain their electronic health record, which often encompasses very complex workflows. And that's a recurring thing they have to do. I recently was with my son at one of the hospitals we go to, and they were migrating to another version of Epic, and it was very disruptive to the care team to try to adapt to those changes. And they occur regularly, at least annually, for most of those EHRs. And then more recently, I was reading in healthcare IT news that more and more industries have to deal with cybersecurity and ransomware disruptions. Just in healthcare alone, 92% of hospitals experienced at least one cyber attack in the past year, which is huge. Why is this important? It results in downtime where hospitals have to go back to paper-based documentation. It disrupts communication. It disrupts elective surgeries that may have been scheduled that now have to be canceled. Care coordination gets impacted as well. And there's a huge monetary blow to these organizations when these events occur, not to mention the liability.
Thank you so much, Sharon, for highlighting all of these challenges. So, how have hospitals adapted to the growing emphasis on quality measures, and particularly in light of these evolving technologies and reporting standards?
One of the best initiatives in healthcare in our country was the introduction of the Meaningful Use and Promoting Interoperability program. This was a monetary incentive program to help the healthcare industry move from paper-based documentation to electronic documentation and standardization. This program has been in place for almost 15 years now and has really improved delivery of care and streamlined electronic documentation. I would highlight three key things that I think are absolutely phenomenal. One being, from a patient perspective, this concept of the patient portal. So where I go to receive my care as a patient, they utilize Epic as their electronic health record. And through that record, I have the ability as a patient to electronically sign into the patient portal and read and receive my information from every care encounter I have. That allows me to see lab results, test results, notes from my provider, my medications. So the patient portal, I think, has been fantastic. Facilitates transparency and streamlines communication. The other one I really think is cool is the electronic communication of prescription drugs. At the time a patient gets discharged, hospitals can electronically send prescriptions to a local pharmacy of the patient's choice. And then those prescriptions get filled and can be picked up by the time the patients arrive at the pharmacy. That process previously was paper-based. Took a long time to fill those prescriptions because it's hand carried from the hospital to the pharmacy. You'd have to sit and wait to get them filled. So that electronic e-prescribing, we call it, is fantastic. It eliminates all kinds of miscommunication, diversion, that type of thing. So that's a fantastic result of promoting interoperability. And then the other piece, and all of this is still, by the way, in full effect, is the health information exchange of information. So electronically sending and also receiving comprehensive patient summaries between providers and inpatient care settings upon transfer. That has enabled providers to know about patient allergies, their medication reconciliation, health histories at their fingertips, almost real time at the point of care. And just in having that information readily available, that has helped to reduce medical errors and better supports patient-centric care as well as patient safety. So meaningful use and promoting interoperability has been a great initiative for our industry to help ensure and focus on how technology can improve the standard of care we provide on a daily basis to our patient population.
Thank you so much for answering this. Hybrid measure submission is one of the newer concepts of in-hospital reporting. Can you please explain what hybrid measure submission means and how does it differ from traditional reporting measures? And why is this a challenge for the hospitals?
So the hybrid measures are I called that a separate and unique swim line, in that it includes reporting readmissions and mortality rates for each hospital. It's not new. These are measures that have been monitored for a very long time. It's a key area of focus, especially from a payer perspective, since I've been working in hospitals. The term hybrid is just a re-engineered version of that type of reporting that's already been established. But several years ago, Medicare introduced the concept that ultimately merges two different sources of data to better calculate and monitor readmissions and mortality. So they're taking the electronic administrative claims data, that's the payer information, and then they're going to be merging that with clinical data that is specific to first documented vitals and lab test results. And then they're going to take this and they'll risk standardize, adjust to calculate a rate that gives the hospitals a fair assessment of any unplanned all-cause readmissions within a 30-day hospital discharge period for eligible patients. These patients will be focused on only Medicare fee-for-service and patients who are 65 years and older that are hospitalized in non-federal hospitals. So it's specific to the acute inpatient public hospitals in our country. It's complicated, so I have a few more talking points. Medicare uses 5 different models for this cohort, readmissions and mortality. They're going to categorize patient populations based on their certain categories, procedure categories. So it includes surgery, gynecology, general medicine, cardiorespiratory, cardiovascular, and neurology. And then based on those groups, they'll determine what readmissions or mortality were maybe planned or excluded from that calculation due to the outcome. And again, like I said, this is based on the administrative claims data, and then it'll integrate the clinical data that includes vital signs and basic lab results. What else to say about that? These are different also in that it is a cross section of a certain time period. So for 2024 reporting, the data was based on July 1st, 2023 discharges through June 30th, 2024. And that reporting deadline just closed. It was October 1st, 2024. So it's a full year's worth of data for both readmissions and mortality that was submitted to Medicare. And then Medicare will turn around and kind of reconcile that clinical data with their claims data. There's no actual score or for performance for the hospitals, but they will receive a hospital-specific report. They call that an HSR. That is anticipated to be released in spring of 2025. So the hybrid measures are a little different than the electronic clinical quality measures, and that it will be one of those areas that will always be monitored just by the nature of their significant cost involved and outcomes.
So Sharon, how should hospitals approach hybrid measure submission to ensure accuracy and compliance with the latest standards?
So I would recommend every year hospitals and providers utilize any and all educational resources that are available. There are amazing webinars and newsletters that are published. One of my key sources I enjoy referencing is the National Quality Forum, NQF. And then, of course, Medicare, CMS provides free webinars and a fairly large amount of resources on their website for these requirements, as well as the Joint Commission. So any hospitals that are accredited by the Joint Commission, they have some excellent webinars as well. And then any local or regional forums, those are always helpful. The other recommendation I would encourage people to look to is utilizing their electronic health record best practices. Meditech, for example, is a great resource. They publish some really comprehensive best practices that outline preferred workflows for clinicians and staff at the point of care, help streamline how to use, their EHR for documentation purposes. I really enjoy when they publish those, and I recommend clients utilize that to help ensure accuracy and compliance. And then the last tool I'd recommend, which is really kind of like the library for electronic clinical quality initiatives, is eCQI. The eCQI website is where you go to reference any new measure logic, any numerator and denominator definitions. And this is really kind of the industry warehouse for measures that are being introduced, new measures, old measures, changes in the measures. eCQI is your one-stop shop resource. So to stay educated, these measures change every year. And just when you think you have it down pat, they change them again. So that constant need for education and information can be accessed through these different resources.
That is completely true. And I think that that was really helpful as well.
Never
So
stop learning.
yeah, exactly. You're right. Absolutely. So I know that we discussed about the challenges for hospitals, but what are some of the other main challenges that hospitals face when it comes to reporting hybrid measures? And are there any specific groups or integration issues that commonly arise?
Yes. So I think every year, again, when we start this cycle of reporting, there are two questions my team always wants to know. One is, are the reporting requirements required or are they voluntary? And off the top, that filters out what your priority focus should be. Then you have to ask, is it applicable to all acute inpatient hospitals, or does it exclude critical access hospitals? Because the critical access hospitals, the smaller community hospitals, might not have to report what the larger hospitals have to report. So that helps to filter out what the priorities are and how it applies to everybody. And then after you do that, you have to understand what the different submission timelines are. So for example, in 2024, we have 4 different reporting deadlines that we are up against. And all of them include a 365-day reporting period. So a full year of data. So you want to make sure you write those due dates down on a calendar in red and then backward plan from there so that you don't miss those reporting deadlines. I think the challenges this year, specific to the hybrid measure reporting, has been how organizations code and map the required clinical data. And then also where you're missing data, where there's no value or null value data fields, there's a requirement where you can't have more than a 10% discrepancy in missing data. So that has been a challenge, and we've worked tirelessly with organizations to identify those and then better capture the data that's likely already there. They just need to get, credit for, where that information has been documented. Lab data, for example, pose new challenges in that some of that data may be outsourced by reference labs and might not be available in an electronic form or a standardized coded field. So we've had to work with organizations to close that gap. And then just a caveat, Medicare was potentially going to change whether the hybrid measures were required or voluntary for reporting in 2024. So some organizations weren't sure if they had to report. So as of the deadline, October 1st, that decision is still pending, and we likely won't know until November whether these measures were actually required or not. So strategically, we advised our clients to go ahead and submit this data so that they would meet the reporting deadline.
That is some great advice. But you're absolutely right. Everybody should just highlight it in red in their calendars to focus on these dates.
Exactly. Backward planning, they call that.
great one. Okay. So what role does technology play in overcoming these challenges? And what can hospitals do to streamline the reporting process for hybrid measures?
So I think just to highlight again, promoting interoperability and meaningful use has been one of the best advances we've seen in healthcare. It has helped to automate and electronically capture patient data at the point of care in these very dynamic and complex electronic health records. So to tell a story, I like to compare the technology in healthcare to the auto industry, for example. So if you compare an electronic health record to a car, a brand of a car, like BMW is like Meditech, we're the Sirius satellite or GPS add-on to that automobile. So we work closely with EHRs to help enhance hospitals' ability to pull the data out of the EHR so they can see what their performance looks like and where they might have gaps in care and where we can help ensure they document all of those required things appropriately, timely, in the meeting the specifications and having all the codes that are required current and available to report to Medicare and other payers. Each EHR is different, but ultimately it's helped to eliminate the need for paper documentation. The flow of communication is much faster than previous years. And like an automobile, healthcare has a safety component to it. And built into these EHRs are safety features where you can reduce or potentially even eliminate patient errors that might result in mortality, for example, or readmissions or bad outcomes. So these dashboards we provide are very valuable. It's a very valuable tool to make sure hospitals can meet all of these changing, dynamically complicated changing measures from year to year.
Thank you so much. So in your previous responses, you also mentioned that eCQMs have become an important part of quality reporting. So how do eCQMs integrate with hybrid measures, and what additional value do they bring to the hospital quality reporting?
Yeah, so eCQMs are ever changing. For years, we've been reporting this data. The difference has been, based on what the priorities are nationally. So the hybrid measures, while they're not considered an eCQM, it is important from a payer and claims perspective to try to reduce, the cost of care for these cohorts. And it also factors in some risk adjustment considerations that aren't necessarily factored in from the eCQM side. There are additional required measures that report on a different schedule. I mentioned that. We have 4 different reporting timelines, so it gets a little confusing, and you want to be sure you know when those are required. And hybrids, like I mentioned as well, the hospital-specific reports hospitals will receive in the spring from Medicare that will identify and help them focus in on maybe needs for performance improvement opportunities. And again, to help reduce the cost of readmissions and mortality. I hope that answered that question.
Yes, it definitely did. But then how should hospitals consider, I mean, what should hospitals consider then adopting for both eCQMs and hybrid measures into their reporting processes, that is?
Yes, so again, they ought to be aware of what the deadlines are. For example, the hybrid deadline we just closed, that was October 1st. So that's done. Those organizations that reported will receive a feedback report from Medicare in the spring. And then they'll have to report them again next year and the following year after that and the following year after that. So I think it gives them a little bit of a head start on knowing what to report and how to document those required data fields. And they'll be in a good place for reporting next year. In fact, we're already in the window right now. Q3, Q4 of this year will be required to report for next year. So they'll be good to go for reporting. Our next deadline coming up for eCQMs is in February. So Q1 will start eCQM reporting. There's 6 measures that are required to report. If they're an accredited hospital through the Joint Commission, they have another deadline for the same thing, eCQM reporting. Medicare and Joint has aligned the quality measure reporting, which has been invaluable. But that deadline for Joint will be in March of 2025. And then there's a new measure that's considered an outpatient measure because it's generally captured in the ER that's specific to STEMI. And that will be, deadline will be in May of 2025. We are currently working with hospitals right now to help ensure they capture those required documentation elements in their electronic record. But every year, organizations need to know and plan accordingly resources to be available to help capture this measured data. We work very closely, not just with the quality teams in hospitals, but with the IT teams, the information technology professionals. And they tirelessly try to streamline and capture this information so it can be reported on time. And again, one last thing, don't wait until the last minute to identify that you're going to report these measures. You really need to plan ahead so that you don't miss out or miss a reporting deadline, which can ultimately jeopardize incentives for reporting and impact your bottom line with reimbursement from Medicare.
Fair warning. Fair warning.
Yes.
So
That's the
speaking
scary
of
part.
us now, so you've mentioned that we are able to streamline the processes, but Persivia has a unique reporting system that integrates claims and clinical quality data. How does Persivia's approach stand out in helping hospitals overcome these challenges of hybrid submission, hybrid measure submission, and how?
Okay, so I'll share my background. I used to be a quality director at a small acute care facility in North Carolina. And I was introduced to Persivia's dashboard, and I was so impressed with it. I changed jobs to join them because it's such a wonderful tool. Makes your
Wow.
job easier as a quality director. And you're constantly monitoring performance from every aspect of care. One of the things that I think is really great is our product is a ONC certified by the Drummond Group. So just to maintain a certified product, we go through a very robust process of validating to ensure we're meeting all the reporting requirements for Medicare. That's something we do on a recurring basis. And as a vendor, that's one of the gold stars that I think organizations should look for to partner with. So that's one point. The other is the dashboard, the actual performance dashboard. It extracts all the required data out of the EHR. So like I compared us to a Sirius satellite on a car, we're the Sirius satellite that sits on top of your EHR. And it allows everybody who has access to the dashboard to monitor on a month-to-month, quarter-by-quarter, year-by-year, patient-level detail performance for every measure that's required for reporting. That includes promoting interoperability as well. So the information about electronic prescribing, health information exchange, patient portal. We also include that in this product, so they can see that, as well as the eCQMs, which include your hybrid measures, readmission, mortality. Other measures we're doing is perinatal care. Those are new for this year. And then the standard ones that have been in place for a while include stroke and VTE, as well as ED throughput, so ED wait time. But we've worked closely with hospitals for many years now to ensure all the required procedure codes are mapped, lab codes are mapped, and other standardized specs that are published by Medicare are appropriately captured in the EHR. And then we pull that data so that dashboard is available daily for monitoring of hospital performance for these quality conditions. What's also unique now to when I first started with Persivia is that we have expanded to include any EHR. So we work with Epic, Cerner, Meditech, any EHR. We're able to pull that data that's required. So it's really a wonderful tool and resource that hospitals have utilized for many years to help improve care. Also, these EHRs may be customized, so not all one hospital documentation program is the same. So we have to work with them to customize queries that they may use to capture this data. And that takes time. So we meet regularly, sometimes weekly, sometimes monthly, but regularly we are in contact with our clients to make sure they're current and up to date on what the specification requirements are for reporting. I have a great implementation and support team that does just outstanding work, tirelessly work. They have extensive knowledge and expertise in our sector of healthcare, and we leverage that every day in these recurring meetings. It's truly a partnership with our hospitals. We want them to succeed and make sure they achieve, the reporting requirements on time. So ultimately, their success is our success, and we have a great product to help them navigate this difficult landscape.
Thank you so much. Can you share some real-world examples as well of how Persivia has helped large-scale organizations in reporting these hybrid measures effectively?
Sure. So I think this has been an interesting case study in and of itself. We have several very large health systems, one that has almost 50 acute care hospitals in their network. And they're large, ever expanding. This organization does great work for communities where I mentioned standalone hospitals might not have enough revenue, so they end up potentially closing. And this health system comes in and pulls them under their umbrellas so they can continue to remain open to provide care that's needed for that community. But in doing so, when they have new acquisitions, these hospitals often are on a different EHR. So what we've seen is many times they're trying to get everybody on one EHR across the network so that information can continue to be streamlined and coordinated and connected. It's about connection. And so let's say, they acquire a hospital that's on CPSI, for example, and the main system is on Meditech or Epic. They try to migrate those organizations onto the same EHR instance. So just in doing that work, it's very challenging. It often takes a lot of time to migrate from one to another. So we work with these hospitals to help often bridge those gaps. And again, I mentioned we meet weekly, monthly. However, frequently these organizations need us to help them to map this data, to get it all on one platform. And it's not just for the hybrid measures, it's for all the eCQMs. We try to have a standard annual product update process that helps guide and steer this work. And some sites, like I mentioned, are unique and different. They might not document everything in the same way, or they're using different other types of records. Like, for example, the OB perinatal care population might be using centricity or OB trace view. So those data feeds need to be migrated into the main EHR, so that it gets kind of complicated, but we work with them to standardize the data as best we can, map it accordingly, and then we extract the data for them. Data tunnel flows, we share data through secure tunnels, and that often needs to be updated for security purposes. And we also are running annual data. So it's a fairly large data set of annual data that needs to get reported. So that gets warehoused, on our platform. And then when it's time to submit, we turn around and we generate those QRDA files that are required. That's the required format for Medicare to QNet for the deadline. So we just finished that cycle for the hybrid measures for 42 hospitals for this one health system, right up until the deadline, which was October 1st. But they all successfully submitted, and hopefully they'll get good, positive health hospital-specific reports back in the spring.
Thank you so much for sharing those great examples. So, but now based on these examples and Persivia's work with the hospitals, what are some of the best practices that you recommend to hospitals looking to transition smoothly to hybrid visual reporting?
Well, the good news is for the hybrid specifically, and we need to pause to celebrate. I told two major health systems recently, we ought to go out to dinner to celebrate that we have completed successfully reporting hybrid measures for 2024. There's a lot of lessons learned there. Again, one of the big things is don't wait till the last minute to plan on what is needed to report. It's a heavy lift in terms of implementing those data changes. So the good news is we've done that. We've mapped the data for the hybrid measures. Come next year, there's only one minor change in identifying the Medicare payer population that will need to be made. But everything else pretty much is in place and hopefully will be stable and easy to report moving forward. Hospitals also have time to utilize our dashboard to make improvements. So some of the IT teams have access to that, and they're able to drill down and use that tool to identify where we might have opportunities for improvement. I should mention these measures also are often timed. So it has to be, the care needs to be done within a 24-hour window of inpatient admission. So you're chasing a clock, and that documentation and timestamp is important. So many of these hospitals are able to see those data elements that might be outside of that timed range in red. So it alerts them to, oh, we missed this one. We need to drill into that to understand why, and then work to improve, reduce, or eliminate those null values or bad values in the data. And then, as I mentioned, once they receive those hospital-specific reports from Medicare, that might offer some additional insights to ultimately improve the patient outcomes to reduce mortality and readmissions.
Thank you so much.
You're welcome.
So looking ahead, how does Persivia see the future of hybrid measure submission and eCQM reporting evolving? And what are some of the innovations that are on the horizon that will impact hospital quality reporting?
Yes. So there was a period of time we thought the eCQM reporting would go away. It is not the case. In fact, in 2024, and I may have mentioned this, but we have a total of 6 measures that we'll have to report. That will be an annual reporting period. 3 are self-selected, but 3 are also mandatory. So the mandatory ones are the safe use of opiates. That's an area of focus at a national level from a payer perspective. And then there's 2 new perinatal care measures that look at your cesarean birth rate and also a severe obstetric complications. So the trend right now is we're focusing more on complications. So in 2025, we'll move from 6 measures to 8 measures, and Medicare will be adding hospital harm, which includes severe hyper and hypoglycemia. Looking out 2 years from there, in 2026, electronic reporting will include 9 measures, expanding from hospital harm focus to include opiate-related adverse events or adverse drug reactions. That's been in hospital focus for a few years now as well. And then 2027, it'll expand to 11 measures from 9. That will include pressure injuries as well as acute kidney injury. The hybrid measures will continue. So outside of those swim lanes for eCQM reporting, hybrid measures will be required as well. It will continue moving forward, and it will expand Medicare fee-for-service and will include Medicare Advantage patients. And ultimately, IQR reporting is expanding incrementally. It's more complex. It's more patient safety focused. It's more outcome based. So future innovations on the horizon, and I know we're talking about doing another podcast for AI. AI will help in a lot of aspects of managing and identifying these high-risk patient populations. But regardless, hospital quality and patient safety will continue to be a key strategic priority from both a payer perspective and also in an effort to reduce or eliminate costly patient care.
Thank you so much. That was
You're
great.
welcome.